Hello, this is part 2 of Analgesic, Anti-Inflammatory, Antipyretic, and Musculoskeletal Drugs. So the second class of analgesic drugs are opioids or narcotic drugs. And in order to understand how they work, we have to understand what happens in our body and how our body can inhibit our own pain pathways. So remember, the pain pathway goes from pain receptors up a sensory nerve to synapses to another neuron in the spinal cord, and then ascends up to the brain and goes to various parts in the brain. Well, our brain is actually able to block those pain pathways. And so we call this descending inhibition, meaning it's coming from the brain and it's coming down and blocking those pain pathways. This descending inhibition uses neurotransmitters that are called endorphins and enkephalins. So when these neurotransmitters are released, they block the pain pathway. And so we can actually inhibit our own pain. They bind to a type of receptor called an opioid receptor. And there are many different types of opioid receptors, and so these endorphins and enkephalins bind to these opioid receptors, and that's how they're active. So the idea behind opioid drugs is that these drugs will bind onto these same opioid receptors and block the pain pathway. So this doesn't happen in the periphery, this happens in the spinal cord and in the brain. Just by the way, we have another way to inhibit pain pathways, and that's by nerves that come from touch. So for example, if there's pain from your finger because that pain pathway has been stimulated, you could rub your finger and that touch pathway will actually inhibit your pain. So that's why whenever we bump our head, we grab hold of it or rub it, and that literally blocks the pain pathway. Okay, so opioid or narcotic analgesic drugs act at different types of opioid receptors in the brain and the spinal cord. We also, by the way, have opioid receptors in our intestine, and when those receptors get activated, it slows down our intestine, and that's why whenever if somebody is taking opioid drugs, one of the side effects is constipation, because those drugs slow down the intestinal motility. So these drugs bind onto those opioid receptors and they block the pain pathway, and this occurs in our central nervous system. So we use these types of drugs to treat moderate to severe pain. We also use it to suppress cough, so they bind to opioid receptors in our cough center in the brain. We talked about they slow intestinal motility, which can be a side effect, or in the case of a drug like loperamide, it actually can be used to treat diarrhea. The other thing is that because there's a large concentration of opioid receptors in our limbic system, which is our emotional center, a number of these drugs that bind onto these specific receptors create a sense of well-being and euphoria, and that's why these drugs are often abused. So So there can be some very serious side effects to opioid drugs. One of the most serious one is respiratory depression. So it slows down respiration to the point where a person may actually stop breathing, particularly if they become very sedated, right? So sedation, confusion, restlessness, agitation, euphoria, those are also side effects of opioid drugs. And if a person becomes very sedated and falls asleep and breathing slows, they can stop breathing entirely, and that's what happens with overdose. It induces a very deep coma and leads to fatal breathing difficulties. If you mix other drugs that have those similar effects, then that can compound that risk. So if you mix alcohol or any other drugs that depress the respiratory system and opioids, then that can cause fatal respiratory depression. There's a number of other side effects: low blood pressure, slow heart rate, headache, dizziness, nausea, vomiting. We talked about constipation, and all opioid drugs have potential for tolerance and physiological dependence. To what extent, that really depends on the specific type of opiate drug that acts on a particular type of receptor. So not all opioid drugs have a similar risk for dependence, but all of them have some risk. Here are some examples of some of the opioid drugs. The ones that are in purple with a star, I'd like you to know those particular drugs. So things like morphine sulfate, or codeine, or fentanyl, oxycodone, hydrocodone, and methadone. Morphine was isolated from opium, which are found in dried poppy seeds, and it was first isolated from opium in 1815. Just a little, dating fun fact, the name morphine comes from the Morpheus, which was the Greek god of dreams, and just by the way, he was the son of Hypnos, the Greek god of sleep. In 1898, they tried to develop another drug that was not as addicting as morphine. Morphine was used to treat pain for Civil War soldiers, and they tried to find another type of analgesic drug other than morphine that would work as well but wouldn't be as addictive. And so in 1898 they came up with heroin, which turned out not to be a very good idea. Fentanyl is something that is been in the news recently because although it's been used in hospitals as an analgesic for quite a long time, recently it's showed up as a street drug, and it's being produced as a powder and then added to other drugs, including cocaine, added to heroin, added to a number of other different street drugs. And the problem is that fentanyl is about 50 to 100 times more potent than any other opioid. So usually, legally, it's prescribed as an injection, a patch, or a lozenge, but when it's illegally added to other drugs, then people may not know the amount that has been added. This little picture at the side shows you a lethal amount of heroin and a lethal amount of fentanyl. So that just describes its particular potency. So a recent study at a harm reduction site showed that 73% that were tested, so these are urine tests, tested positive for fentanyl, but only 30% of people actually reported using it. So the majority of people that had tested positive had no idea that they were even taking fentanyl. Codeine is found in things like Tylenol number 3. It's found as a cough suppressant, as is hydrocodone. Methadone is used to treat recovering drug addicts. So it acts at many different opioid receptors, but it doesn't act at the ones in the limbic system, so it doesn't produce euphoria. So what they use is they use it to prevent the withdrawal symptoms as they reduce dependence on a particular drug like heroin. A note about naloxone. So naloxone is an opioid antagonist. So naloxone is used to reverse the effects of an opioid overdose. So it binds to opioid receptors, doesn't activate them, but then prevents the opioid drug that is circulating in that person's body, prevents those drugs from binding onto the receptors and having an action. And so a person that is experiencing an opioid overdose and have trouble breathing or stopped breathing can be given this drug and can reverse the effects of that overdose. So you can give it as an injection, so it is available as an auto-injector, or even a nasal spray. And so you'll find some of these naloxone kits around the community. You'll find several of them around the college, so they're located in places like the Students Association, security, the health office, counseling centers, so they have them in various places in the college. You need to use extreme caution when handling fentanyl because it can be absorbed through the skin and through mucous membranes. So you have to avoid touching your eyes or nose or mouth, and if you get any onto your skin, you have to wash right away because even a small quantity can cause a very serious adverse reaction, including death. So if you are helping somebody with a naloxone kick, just make sure that you're not touching any of the drug itself. An anesthetic is a drug that blocks not only the pain pathway but blocks all nerve impulses, so including things from touch. And so that's why when we use a local anesthetic, we get an entire loss of feeling in that area of tissue. So usually it's used to prevent the perception of pain while they're doing some sort of procedure like minor surgery. You can inject local anesthetics, or you can use them as topical. For example, some types of creams for cold sores contain a local anesthetic. Toothache drops are a local anesthetic. They can be injected into the cerebral spinal fluid around the spinal cord, and that numbs everything, all of the sensation from that point down. So that's the principle behind a spinal or an epidural anesthetic. Just by the way, cocaine was one of the very first local anesthetics used, and what they noticed is that when they put it on their tongue, that it caused numbing of their tongue, and so they added it to all kinds of kids, teething drops and and everything until they understood exactly the mechanisms behind that drug and the dependence and issues that occurred. So this is an old advertisement. So just to recap. So down in the periphery, by our pain receptors, this local anesthetics can work here, as can our anti-inflammatory drugs. Local anesthetics can work on peripheral nerves or in the spinal cord. Opioids work in the brain and in the spinal cord, and acetaminophen we know works in the brain. A note about cannabis. So as medical marijuana is being used more and more, the active ingredients is THC, tetrahydrocannabinol, and there hadn't been a lot known about the mechanisms of how this actually works and the role it plays in treating pain. What they have found is, and this was a study that was done last year, is that it does provide pain relief, but it is not considered an analgesic drug because it does not block the pain pathway itself. So it doesn't reduce pain intensity, but how it works is on our limbic system, so emotional centers in the brain, and it affects our perception of pain, so makes our pain more bearable. So for some people, because it's not physiologically blocking the pain pathway, for some people this works really well, and others it works very poorly or not at all. And this is a spider web done by a spider using cannabis. Another note about migraine headaches, and you can find more information about migraine headaches on page 73. So a migraine headache is caused by changes in the diameter of blood vessels surrounding the brain and the scalp. So the first stage of a migraine headache, the blood vessels that surround the brain constrict, and that reduces blood flow to the brain. And then in the second stage, the blood vessels in the scalp dilate. And this creates a very severe headache that is often accompanied by nausea and vomiting. Sometimes in the first stage, you'll see a person will experience warning signs, so visual disturbances or numbness and tingling, maybe even speech impairment. And these migraine headaches can be triggered by a variety of different things that will be personal to that particular individual. So it could be anything from physical exertion, a blow to the head, certain foods, drugs, emotional factors like excitement or tension or shock or those types of things. The underlying cause of migraine headaches isn't known. We know that it involves neurotransmitters serotonin and dopamine. Often there's a family history component as well. There's no cure. Sometimes people will have a migraine headaches for a while and then they will stop having them, and some people have them for longer periods of time. The drugs that we can use to help manage migraine headaches are twofold. So one is that we can prevent a migraine headache if we can prevent the blood vessels from initially constricting. So this has to be taken before the migraine headache actually begins. And we also have drugs that could relieve the symptoms of migraine headaches. So drugs that cause constriction of the blood vessels in the scalp, and that helps prevent the second stage from occurring, or simply taking analgesic drugs to relieve pain. Antipyretic drugs are drugs that reduce fever, and again, fever is linked to the production of prostaglandins. So any drugs that will inhibit the production of prostaglandins will reduce fever. So the way fever works is that when a pathogen invades our body, our white blood cells or leukocytes get activated, and they produce a chemical called a pyrogen. Pyro, again, fire. Or they could even be something we call exogenous, which means that the bacteria themselves that enter our body produce pyrogens themselves. In either case, these pyrogens stimulate the production of prostaglandins, specifically prostaglandin E2. So if we can inhibit this production of prostaglandin E2, and that's what things like acetylsalicylic acid or ibuprofen do, then we can then prevent these prostaglandins from telling the hypothalamus to raise the body temperature. Acetaminophen inhibits the production of prostaglandins, but again, that's not in the periphery, that happens right in the brain. In either case, without these prostaglandins, then our hypothalamus lowers our body temperature and fever will be decreased. The last section that we're going to look at are musculoskeletal drugs. And so these are drugs that are used to treat musculoskeletal disorders, which could be anything from an injury, like a ligament injury or strains, sprains, fractures, things like that. It could be inflammation, so things like tendinitis, or it could be more chronic diseases like arthritis or osteoporosis, or it could be a muscle issue like hypotonia or hypertonia, so spasticity or low muscle tone or atrophy of muscles. So we just discussed anti-inflammatory drugs, so these are definitely also considered a type of musculoskeletal drug because they reduce inflammation and they can treat the symptoms of lots of musculoskeletal disorders, including both acute injury and also things like osteoarthritis or rheumatoid arthritis. So our anti-inflammatory drugs include our NSAID drugs that we just talked about, our COX-2 inhibitors like Celebrex. It also includes corticosteroid drugs that we talked about in week 12, and those are also very powerful anti-inflammatory drugs. Muscle relaxants are drugs that are used to relax muscles that are associated with muscles that are spasming or stiff, or ones that have abnormal contraction, hypertonia. They are not an analgesic drug, so they don't block the pain pathway, they don't reduce inflammation, but they will cause a muscle to relax. Some muscle relaxants work in the brain, in the spinal cord, and some work directly in the muscle. And again, they decrease muscle spasms and promote relaxation. Some are designed only to be used for a short period of time, and these are usually used for acute conditions, so things like injury. So an example of this would be diazepam or Valium, so that relieves muscle spasms, so a person could take that over a short period of time. Methocarbamol, which is the active ingredient in Robaxin, same idea. So if somebody has a very painful, stiff back and there's muscle spasms because they worked too hard or they tweaked something, and then this would be a drug that could be used for short term. if there's issues with muscle spasticity over the long term, there are better drugs that can be used for longer periods of time. And there are two main ones. One is dantrolene, and it has a direct effect right on the skeletal muscle. It reduces the amount of calcium that enters the muscle, and therefore the muscle doesn't contract as much. And so people with spastic cerebral palsy or multiple sclerosis, this may be a drug that relieves some of that spasticity. Baclofen acts like an inhibitory neurotransmitter, GABA, and it works in the brain and the spinal cord, and it inhibits those spinal reflexes. And if you remember from physiology, it's those spinal reflexes that create muscle tone. And in people that have spastic muscles, they have these exaggerated spinal reflexes. So this inhibits those spinal reflexes and therefore reduces muscle tone. So people with spinal cord injury, ALS, multiple sclerosis may use this to decrease that muscle spasticity. Another option is botulinum toxin. So this is a toxin that is produced by a bacteria. The bacteria is Clostridium botulinum, which is the same bacteria that causes botulism, which is if we consume it orally, then it causes vomiting and diarrhea and is a gastrointestinal disease. But this bacteria produces this toxin, and the toxin actually inhibits the release of acetylcholine at the neuromuscular junction. So at that place where the nerve would normally excite the muscle, it blocks the release of that neurotransmitter. And what this does is it then, without that neurotransmitter exciting the muscle doesn't contract as much, and it becomes a lot less stiff. So this toxin actually has to be injected directly into the muscle. It usually takes about 2 weeks to have an effect, and the effect will last about 16 weeks. And then they'll need another injection. The last section that we'll look at is just drugs that are used to treat the two main types of arthritis that we discussed in physiology. So if you remember, osteoarthritis is where over time or with excessive wear, the cartilage that covers the ends of bones starts to break down. And as a result, bone rubs on bone, and that creates bone spurs, and that inhibits the movement of the joint and causes pain and inflammation. So some of the drugs that are used to treat osteoarthritis are to prevent pain, so oral analgesic drugs. Again, you have to be careful that you're, when you're taking analgesic drugs, especially things like NSAIDs, that you can have stomach lining problems if you take them over long periods of time. Inflammation can be reduced by NSAID drugs or COX-2 inhibitor drugs, both of those. Corticosteroid drugs are usually injected right into the joint itself, and again, that can only be for the short term. In any given joint, you can only do 2, maybe 3 corticosteroid injections, and that's it. Sometimes there's some topical analgesic drugs like menthol salicylate, which is or Bengay. So this is a counter-irritant type of thing that, again, may help reduce pain by acting on those touch receptors. Or there is something called hyaluronic acid, and it is something that is secreted normally inside the joint capsule, and it lubricates that joint. If it is injected into the joint, then it can cause more lubrication in the joint itself, and that can be very helpful for reducing friction between bones and so on. For rheumatoid arthritis, remember that is an autoimmune disease, and so it's where the immune system has actually attacked the cartilage inside the joints. So there are 2 main classes of drugs used to treat rheumatoid arthritis. One are just to relieve symptoms. So, for example, analgesic drugs to reduce pain, and anti-inflammatory drugs to reduce inflammation. However, there are some drugs that try to slow down the process of the disease and prevent the joint from becoming permanently structurally damaged. There's a couple different types. There are ones called DMARDs, disease-modifying anti-rheumatic drugs, so things like methotrexate, and they act fairly slow, so it may be weeks or months before a person notices any benefit. They likely work to reduce the immune response. There's another group of drugs called BRMs, or biological response modifiers. They're the newest ones. They target the immune system, and they're given by injection, either daily, weekly, or every 2 to 4 weeks, and they suppress the immune system to try to prevent it from destroying the joint. That's the end of the presentation. Please make sure you do the online tests, and questions will also be on your final test. Thanks. Have a good day.